Now we have already started the registry for diabetics, childhood diabetes. So I'm wondering about the metabolic also syndrome. Why not to have a registry, maybe through the diabetes registry or on its own? Because really it's, as you said, in Mubarak you have so many, and I think others, hospitals should also be involved to have a registry about it. So it's just a recommendation or a suggestion, inshallah.
Dr. Azza worked very hard on that, and it's very difficult to put this question and answer this. And with the metabolic syndrome, with the variety of definition, variety of the blood levels, so you need to standardize all these blood levels among the hospital, which is difficult in Kuwait. So you have to standardize all these and synchronize them. Then you can do the registry. But I'm sure in the future we can add, because already we're adding type 1, like associated type 2 and other association like blood pressure, and but I don't think we can add more in the future, but I think we can think about these lines. Maybe Dr. Azza can comment better on that. You don't have
Thank you very much, Dr. Mona, for your question. We are certainly interested in the registry for children with diabetes, and those are a confirmed diagnosis with diabetes. Now, in Dasman, we have also our head of epidemiology statistics department did a research study on screening in schools, and was able to do the screening for 9,000 kids. And they looked into risk factors, and they looked into the children who had impaired glucose tolerance, and also those who were having criteria for the metabolic syndrome. But this is always good as a research project. Now, to have a registry for all obese children, that may be quite difficult, and but another option is introducing electronic health records in the schools, and this is another project that is being done in Dasman, which is Let's Get Healthy Kuwait, and in those this is again a program which is trying to teach children how to make good choices about their food, and also the importance of physical activity combined with introducing electronic health records in school. Again, this is part of a research project. Now, once we have the results of those, then one can advise, the Ministry of Education to adopt a more generalized adoption of the registry. But at the moment, we're doing just the diabetes, and this is based on the previous Diamond study that was published in the 90s. Thank you.
We have one last question for dietitian Ali. Okay, sorry, there was Dr. Rahni.
Good morning, everybody. My name is Dr. Nawar. I would like to thank, first of all the speakers for their comprehensive talk. And then I would like to comment on Dr. Philippe's, who was telling us that there is no hope. Well, I do believe having this great conference, interesting conference in Kuwait is a great hope for us. And the second comment will be about the social media and the TV. We are actually addicted to TV in Kuwait. It's extremely important to address the fact that we have to highlight the possibility of having more obesity because of, and also in another hand, even the possibility of having anorexic patient because of the TV. It's really important to change the, idea of having a suitable or a normal weight, not having too much low weight or too much high weight, by even addressing that or that fact through the TV, through the social media as well. Thank you very much.
Could I just take that up and say we're actually in a very delicate position. I don't know how much you know about the control of TV here. We're actually, through the World Health Organization from Cairo, we're looking at the GCC and what the regulations are in relation to the GCC. For those of you who don't understand, the fact is there's a problem here because you have television coming in from everywhere. And the question is, how do you control it? And what you don't sometimes realize is you have relay stations for television. And if you had tough government, because you can go around the world and everywhere the food industry and soft drink industry is targeting children. And it doesn't matter where you are, it's true. And you need very active children's parents and activists who force the government to not allow their local television to have any adverts for soft drinks and so on. And people say in children's television, children watch adult television. So in France, they're now banning adverts for these things unless they pay a tax. You cannot do this in the Middle East unless you have a combined action. So if the GCC did not allow CNN to be broadcast in the Middle East unless they complied with their local distribution channels, you would be amazed how fast CNN would change. Same with every other channel. And I don't think that the governments of the region, just as in Europe, we have stupid governments in Europe as well, you have to actually wake them up and tell them exactly how to do it. So I, for the last few weeks, have been involved in the trade negotiations relating to trans fat, because we're starting with trans fat, but exactly the same happens. And marketing to children has been agreed by all health ministers in the world should not happen. We're doing nothing about it, and we're going to suggest in Cairo very shortly specific legal measures to start coping with these things.
Hi, just a quick question for Dr. Schulenberg. So I'm a clinical dietitian. I'm here. So yeah, Dr. Schulenberg, thank you for your talk. I just have a quick question. As you mentioned, the eating behavior, abnormal eating behavior is a complex issue. And being a clinical dietitian, it's hard to like sort of decide or identify a specific problem that the patient has. So it's a complex issue. So can you maybe guide us or give us an advice, sort of where is the best good point, what would be a good point to start, or what would be the best starting point for us? From where do we start, basically, in tackling these issues while counseling the patients?
When you get someone into your office, quickly there's an assessment, and if you come get my card, I'll give you can email me. There's an assessment that assesses eating behaviors and for emotional eating. And that's the place to start. And then the second thing that you need to do is a lifestyle assessment. There's so much in terms of talking about abnormal behavior that I couldn't cover in 20 minutes, but you're looking for things like patterns of eating. You're looking for emotional-based eating, uncovering the rules, the unstated rules. My colleague after me talked about cleaning off your plate. When I was growing up, that was a rule as well. You couldn't leave the table till your plate was clean. Those are rules that we absorb in childhood, and they impact our adult choices, but we don't know they're operating. So part of assessing what needs to be done for a patient or to begin a lifestyle renovation is to bring those things to awareness. And the two tools that I would tell you about are the emotional eating assessment and motivational interviewing, so that you get a picture of the client's lifestyle in a way that is affirming and validating in terms of what they're doing, and attaches no shame, no judgment, and no blame to the position they're in, because as soon as you do that, you're finished.
Okay, thank you.
Okay, thank you. Thank you to all our speakers. We'll take a short break and reconvene at 10:30. Thank you.
We're going to start, and otherwise we're going to be a little behind time. And I'll introduce the first two people. And the first person is Dr. Susan Bartlett. And she has a very distinguished career in a clinician and trained in psychology and psychiatry. And she trained with two of my heroes from the United States, Mickey Stunkard and Kelly Brownell. And she's been at Johns Hopkins, and she's now in that beautiful but very cold city of Montreal in Canada. Over to you to talk about the role of primary healthcare physicians in the management of obese patient. Very important topic.
They do. In fact, one of the things I wanted to do was talk with the organizers about, couldn't we extend this to, say, primary care providers? Because what I'm going to say is every bit as applicable to every member of the team. And in fact, I think that we're much further ahead when all members of the team are echoing the message that I'm going to talk about this morning. So I put this slide up to remind myself, to remind you, that I do come from a very different place. This is about what it looks like back at home right now. And I understand they're getting another snowstorm before we get back there. So thank you again for the invitation. It's delightful to be here. But our culture is different, and I'm going to talk with you about what has worked in my setting. But I've worked in a number of different settings. I started in Montreal. I moved to the United States. The cultures are very different there. And I found, though, that the patients were very much the same. The strategies that I used with patients were the same. The strategies that I taught the physicians and how to work more effectively with patients really were much more universal than they were different. So I'm imagining that we're going to find the same thing here. I want to start by saying what you say is really important. And talking with your patients around their weight is critically important. In fact, not saying anything is the worst thing you can do. Your advice really does make a difference. I know over time we feel, at least in my setting, like patients aren't listening to us, that we say the same things, they hear it so many times they don't seem to act on it, but in fact they do. And in our culture, they tell us still, the doctor and the healthcare team is very much their major source of information. In fact, the statistics here, 75% of their Americans see their doctor at least once a year. That makes primary care providers ideally suited to be working with patients around weight, because we have a long-term relationship with people. And we see them and we're working with them around their health. The majority view their doctor as their primary source of information. Yes, they go to the internet. Yes, they talk with their friends. Yes, they read things in magazines and they get information from other sources. But they still continue to see the medical team as the authority of credible information when it comes to their health. And this is what's really important. So if you don't remember much from this talk this morning, remember this piece. 93% said that they would try to follow their doctor's advice. Again, I'm saying it applies to the team from my experience. But they would try, if they were encouraged by their healthcare team professional to do something about their weight, to think about their weight, they will act on this information. They probably won't act on it the first time you bring it up. What I'd like you to think about is starting a discussion that evolves over time, a discussion that you keep coming back to and revisiting. You're planting seeds each time you're meeting with your patients, and you're introducing some new ideas slowly and gently as we go along. But over time, those seeds really do take root, and some amazing things can happen. Why are primary care providers so well suited to do this? Well, as I said, you have the most contact with patients, and you're talking with them specifically around your weight. That said, in our setting at least, we don't do a very good job of preparing the primary care providers to be able to work with patients. They learn very little about obesity. At Hopkins and at McGill, I do a lot of the teaching around obesity. And if we're lucky, they get a couple of hours throughout their medical school. So of all the things they're learning only a smattering of information. And that's why for the dietitians who are in the room, your role is absolutely essential here. Because, at least in my setting, most of my colleagues really don't have the kind of information or the ability to talk about healthy eating in the way that you do very naturally each and every hour of the day you're at work. We're living in difficult times because the message out there from a number of corporations, weight loss is a huge, huge industry, as everybody knows. In the United States, it's about $35 billion a year, big numbers. But the message is that weight loss is simple and easy and anybody can and should be able to do it. You know, you just have to take this supplement or go to this program or enroll in this program. And essentially the message that we give to patients is the work will be done for you, all you have to do is just show up. Of course, everybody in this room knows that that's the furthest thing from the truth. But what we really need is this consistent message of what does work, what it takes to lose weight, and why it's so important, why it really makes a difference on health, not just on how people look, but how they feel and how healthy they're going to be over the course of the lifespan. So when that message comes consistently from the pharmacist, from the dietitian, from the doctor, from everyone on the team, that's when we're really able to move patients forward in the right direction. Do doctors talk to their patients? I could find information about what goes on in North America, and disappointingly, even though we've been talking about this for more than 30 years, what we find is less than half of doctors ever bring up weight to their patients. So about 48% will link a health condition with the patient's weight. These are in individuals who are overweight or obese. They will talk with them about diet and exercise, though the advice doesn't seem very helpful, quite honestly, is what patients tell me, because they're simply told you need to eat less and you probably need to exercise regularly. Very rarely will they be referred to a program, offered medication if it's indicated, or even referred for surgery. So we have lots of room for improvement where I am in terms of just really getting the tools that are available and would be helpful to people in the right hands. If you look in the general population, anywhere from 29 to 42% have had a conversation at any point with their healthcare team about their weight. And even more striking, I do a lot of work in arthritis, so in people with arthritis for whom we know maintaining a healthy weight is critically important, be it inflammatory arthritis or osteoarthritis, less than half have conversations with their doctor around their weight. I've done studies, and we've shown in our studies that losing as little as 10 pounds can decrease pain by 50%, can improve physical function by 50%. We don't get that kind of improvement even with narcotics. Just a 10-pound, which would be what, about a 6-kilogram weight loss, can make a huge difference in people with arthritis, but we're not doing a good enough job getting that message out. So what I'm going to do is talk about 5 key messages that are really important. These messages come from guidelines that have been developed over the last 25 years or so. New guidelines came out in the United States in November. The guidelines are fairly similar to the original guidelines that came out in 1998. And that's good news because it says we're on the right track and we're doing the right kinds of things. But I'm going to run through with you what the 5 key messages are that have been identified. I've taken a little bit of liberty. I've put a little of my own opinion in here, and I'll let you know where I've done that. But the 5 things that can make a difference. And here they are. First of all, we need to be able to reliably identify who needs to lose weight. We need to give consistent and regular messages about the importance of losing weight, the importance to health, how much weight loss is needed. That's the biggest surprise to most people. Most people think they have to lose 30 or 40 pounds or they have to get back to the weight they were when they were married for it to count. Well, they don't. Even small amounts make a big difference. Here's where I'm going to put my own 2 cents in. I think it's really critically important that we help patients assess whether they're ready to make a serious weight loss attempt. There's increasing evidence that if you try to lose weight and you're really not ready, you may set yourself back further. There's biological evidence that it can be problematic to weight cycle. I'm more interested in the psychological evidence. When people fail at losing weight, to them it becomes harder and harder to think they're going to ever be successful. So we need to keep that in mind. And then I'm just going to touch on what is the best approach, because you're going to hear a lot more. You're going to hear more of the specifics of diet, of physical activity, of all the components that really do make a difference. So let's start with who should lose weight. You've heard lots around this, so I'm not going to spend much time other than saying, in the United States, the guidelines say that we should be talking with everyone who's overweight and obese, but the messages are different. So for individuals who are overweight but not yet ready to lose weight, individuals who are overweight but don't have additional health weight-related conditions, medical conditions, the message that's recommended at this point is it's important to stay where you are if you're not ready to lose weight. Don't gain additional weight. And when you are ready, there are all kinds of benefits and reasons to think about losing weight. But that was a new message that really evolved during the time after I was trained and had worked for a number of years. For individuals who are obese, of course, there is clear evidence of the benefits of losing weight. So what the guidelines recommend is that we need to be routinely screening patients at least once a year, measuring their BMI. When I go through the charts in my institution and we're doing research, I find that very rarely is BMI recorded. Almost never is height recorded. So it becomes a huge issue because this is the easiest way for us to have a sense of body composition. You know what the guidelines are around BMI: overweight 25 to 29.9, 30 and above, of course, classified as obesity. In addition, waist circumference makes a difference. So how portly people are. For women, 88 centimeters, a waist circumference greater than 88 centimeters, and for men, 102 centimeters confers additional risk. And that's important because what we're going to do is we're going to try and link weight with health conditions with patients. That's very important. You need to be able to relate it to the condition that they walk in talking with you about. If they're having problems with their knees, if they're having problems with low back pain, you want to skillfully, empathically, and in a non-judgmental way, but clearly link that with weight because we know there is a close link. Individuals who are at very high risk because of their weight, those with coronary heart disease, diabetes, obstructive sleep apnea, any of the obesity-related diseases such as arthritis or gallstones. For older women, stress incontinence, problems getting pregnant, other gynecologic abnormalities. We want to look at the cardiovascular risk profile. These are the common risk factors, but you know what the new one is now that we really need to be paying attention to because it's proving to be as potent as anything on this list? It's what you're doing right now. It's what I do way too much of the day. It's sitting. And we know that sitting as little as an hour can really change your lipid profiles. Our patients spend a lot of time sitting. We need to be talking more about this, and you'll hear more about that tomorrow. And then sedentary lifestyles in general, high triglycerides. These are all markers of people who are at additional risk. So again, if they're overweight and they have 2 or more of these risk factors, the guidelines suggest those individuals have clear benefits from losing weight. If they have fewer than 2 of these risk factors, then the advice again is to work at not gaining any weight. Stay stable where they are, and when they're ready, think about reducing. So how do you start this conversation? Because it is a bit of a difficult one. Many of the physicians that I train are very, very uncomfortable raising the issue of weight, and I work with them to try and get them over it because it's part of what we do. It needs to be part of the conversation, but it needs to be done very respectfully. And so ways in which I've found it's often helpful to start the conversation is first to ask permission. I'd like to talk with you about your health and your weight. Is that okay? Is that something that you're agreeable with today? Once I have their permission, and I haven't had anybody say no yet, it may happen, but so far they've been good, then I ask them to tell me how they feel about their weight. Is your weight a concern for you? Is it something that you've worried about? Are you gaining weight recently? Are you concerned about that? As they start to talk about their weight and they are more comfortable talking about their weight, then I have a lot more information to be able to work with. And then I'll ask them, have you tried losing weight? What have you done? What's worked? People always like to talk about what's worked. But I also want to know what didn't work. Where did it fall apart? When we have these conversations, it's a different kind of conversation with patients. And I've had my patients say to me, you know, they went in and they had been working on their weight and they lost, let's say, 5 kilograms. And they went to the doctor's office and the nurse put them on the scale and noticed they were down 5 kilograms. And that kept them going. Just that noticing the change in their weight kept them going for another 3 months. All of my magical psychological strategies that I was trying to use to motivate them weren't nearly as powerful, it proved to be over time, as just the recognition from the healthcare team. Because as patients have said to me, you know, it's not very often your doctor compliments you for doing something right. Usually what they're telling you is all the things that you're doing wrong. So when patients are making gains, when they're changing their eating, when they're, even if they're not gaining weight, these are things I think we need to get excited about, we need to be very reinforcing about, and we need to give them lots of feedback. That's terrific. How did you do that? Tell me more. What are the benefits of losing weight? You've heard lots of that, so I'm not going to spend much time on this, other than to say you only need to lose small amounts of weight to get about 80 or 90% of the benefits. So we see things like triglycerides and glucose and diabetes risk profiles change dramatically with even as little as a 5% weight loss. There are many psychological benefits too, and I don't want to lose the opportunity to stress that as well. How people feel about their bodies and their weight has quite an impact on their quality of life overall and their mood overall. And I'm going to spend more time talking about that in the workshop this afternoon. So how much weight do they need to lose? Well, small losses give big benefits, 3 to 5%. So losing as little as 6 or 8 kilograms really does make a difference on health. Often people who lose 6, 8, 10 kilograms can come off many of their medications or have them reduced significantly. That's a huge bonus because a lot of these medications are problematic. The medications we give them for diabetes, the medications we give them for blood pressure, well, in fact, those medications cause them to gain weight. And then the last 2 steps of this are finding out with your patients, having a conversation, are they ready to do this now? Is this the right time? Because if it's not the right time, then what I would suggest to you and what the evidence would suggest is that it's better to wait. In fact, it's better to wait until somebody really is ready to take this on. If they have a big event coming up in their life in the next couple of months, this is probably not the right time to try and tackle a major lifestyle change because it's going to require a lot of energy. It's going to require time. It's going to require a lot of mental energy and commitment. So I want to make sure that they're doing it at the right time. I want to make sure that mentally they're ready. Have you heard of the stages of change model and when people are in pre-contemplation, contemplation? You've already talked about that. You will be talking about that. Wonderful. So